So, hopefully you can all hear me pretty well. Is it loud enough, right, like this? Okay. I'm admittedly somewhat intimidated. Hopefully that makes sense. Nurses are fantastic, so I appreciate being here. I don't know that I've ever given a talk just to a group of nurses in this kind of situation, so it's exciting to be here. So let's get started. I have no financial interest or anything like this. That's my disclosures. I like to start out by demographics. This is how I start all of my talks, and just to be up front, don't mind comments and things like that during the talk. I prefer to have a discussion if we can. So those of you that are nurses, if you can raise your hand and kind of make sure just about everyone. So yes, you fit the dual category of a nurse and a nurse practitioner. Any others, the nurse practitioner or, okay, so we have a few nurse practitioners, that's wonderful. And then any other physicians, I know there's a few of us here, I know Yusuf, okay, wonderful. And then demographic-wise, everyone works in oncology, or raise your hand if it's oncology. What other areas do we have that people here that are working in?
I work on a medical telemetry unit with some oncology beds.
I see. Okay, so you kind of you're an inpatient in the hospital, kind of do a hybrid with the telemetry unit. Good, good. That's perfect. Who else?
I work in the emergency department.
Oh, fantastic. Good, good. I'm trying to think if I can make some comments related to that work. Part of my job is I do a lot of inpatient palliative care, and we do interact a fair bit. We wish we could interact more with the emergency room. You probably get many of these patients that come in and they're either on hospice or they're severely ill, or somebody that's been in a memory unit or something that's fallen and has a big head injury, and you have to decide what to do on the spot. They haven't had advanced care planning. They don't have good description of what they want in their health care. I can imagine you've seen those cases, right?
Or the opposite. They have an advanced care, they're on hospice.
And they're still in the emergency room. Correct. Yes. So both scenarios, very, very well stated. That's good to hear, and those are things that we have to try and, I don't want to use the word deal with, but try and navigate, because it's hard. Families panic. People have a hard time with that. I'm spending a little bit of time on that because it's not necessarily fully part of what we're talking about today. But okay, who else? Any other locations of work? Is that mostly it? Okay. All right. And then most of you are from this area north, or where else are people from? Go ahead.
San Francisco Bay Area.
Okay, good, good. San Francisco? Oh, wonderful. That's great reach if you can, spread the word. Like I said, I'm very thankful to Binay and the others that have helped organize this event, and definitely want to see it grow. This is a great group to begin with, though. So Coeur d'Alene's a good place to visit for a conference like this, for sure. Let's see. That's probably enough. It helps me just get an idea of who I'm speaking to, so I can adapt on the fly. The next one that I put up here is, what questions do you have? I often feel like I can come and speak and just say a bunch of things that may or may not be relevant, but I like to hear if you have seen this topic and have any particular thing you're just dying to hear an answer to. Is there anything like that among the group? Is there something that you specifically want to hear? Go ahead.
My biggest frustration is I like the concept of palliative care, but what's actually offered in palliative care accommodation.
Okay.
A whole other situation.
Great question. Now,
Yeah,
tell me a little more about where you work and what is available. I think that's it's a real struggle. So as you probably saw, I'm going to go up a little bit. I have a number of different titles on here. So the bottom one is I operate a house calls based palliative care program, and the hardest part of that is how do you get reimbursed and paid for doing that service at home when it's not hospice, like you're saying, when they're separated, because the payment model is very, very challenging. So we are doing a whole extensive amount of work with regards to the billing and all of that, as well as negotiating with insurance companies, because you have to get paid to do that service. And so, and actually, at one of our branches in Utah, we're starting a deal with one of the insurance companies at the beginning of September to do home-based palliative care under a different payment model than fee-for-service, which opens up a whole bunch of different windows for providing social services and other cares at home under the palliative care umbrella, not the hospice umbrella, if that makes sense. So that is something that's ongoing, and it's a big challenge that the palliative care as a specialty faces, and we're working on it. Hopefully it'll come around. The best thing for all of this is the value-based care systems that are being implemented through CMS and things like that, which helps the most. But the biggest struggle that we have right now is exactly that. We can't fully implement the full value of palliative care because of reimbursement. The only person that gets paid is a physician or a nurse practitioner that makes a home visit, and it's challenging. So let's see, and then your question, we will talk a little bit about that, the division and all of that, but that is a symptom, that what you're describing is a symptom of a new specialty. So palliative care is only, was basically triggered, and we'll talk a little bit about it in 2010. So pretty early, I mean, it's been going on for a long time in conjunction with hospice, but it really has gained traction since about 2010, based on one study that we'll talk about today. There were a couple of other questions out. Go ahead.
One of the challenges for me has been many of the medical oncologists I work with struggle to or shy away from discussions with patients about end of life, about palliative care. They tend to just focus on what we would hear now.
Yeah.
And so that those discussions are delayed far too long.
Yeah. So we will address that one today. Yes. So you had a question.
With the COC stating stage 4 needs to be referred to palliative care,
Yeah.
but then you can't get palliative care to really come in, how do you deal with that?
It all depends on the scenario, and because it's a new specialty, different areas. So, for example, in Boise, where I practice, 2 years ago we started a clinic that also had house calls associated with it, as well as inpatient service. So that's a group that has a lot of different options for palliative care. Not every group, the group that I work with for the past 10 years was purely inpatient palliative care and ICU based, and so not very community available. And so it's a growing process, and there are many people like my group that are in this fight of how do you get this reimbursed, and how are we going to implement this? How are we going to get into the minds and thoughts of the nurse and the oncologist to say, hey, it's okay. We're not just going to go transition them to hospice or go tell them to convince them to stop doing chemotherapy and things like that. Those are often difficult conversations to navigate. And then on top of that, because it's a new specialty,